Hispanic patients are less likely to be started on PD, right? But for me, I say, okay, hold on, because we're saying racial and socioeconomic factors, right? So what if we factor in the socioeconomic factors? So the odds ratio of starting on home dialysis after adjusting for patients' demographics, patients' medical conditions and the medical factors, and the patient's socioeconomic factors, you'll notice that they're different, right? So when we look at it from the perspective of, just the odds ratio unadjusted, these are the chances of being started on home dialysis by race, not factoring in anything else. You'll see, and again, you'll see the Black patient population, so 0.69, 0.81. For reference, right, if it's less than 1, that means that you're less likely to be started on it, right? So in this case, right, 0.69, it's 0.31 below 1, so that's 31% less likely, right? And the same thing for the Hispanic patient. And then you turn around, you look at the Asian patient population, like, hey, the Asian patients, they're doing far better than everybody else, right? So it's like 130%, right? So they're 32% more likely to be on a home dialysis modality compared to your average white patient. But then after you adjust for it, look at how things kind of start to normalize closer to 1. Right? So the 0.69 becomes 0.76, the 0.81 becomes 0.9, and the 1.32 goes all the way down to 1. So when you adjust for it, there is no difference between the Asian patients and the Caucasian patients, right, or the white patients, and the Hispanic, and it kind of closes the gap a little bit between the Hispanic patients and the white patients and the Black patients and the white patients. And I say that to say that this is not just all race, right? So all these things do play a role in determining our patients' outcomes, right? So when you factor that in, yes, Black patients, even when you adjust for it, and Hispanic patients are less likely to be on peritoneal dialysis or on a home dialysis modality. Now, let's keep building on this racial and socioeconomic factors. Look at patients who are dual eligible for Medicare and Medicaid, and patients who have low income subsidies, right? And if you take those patients into account, 21% of those are Black or African American, and 18% are Hispanic or Latino. And then, so the vast majority are not African American or Latino, right? So they looked at 36 clinical care measures. So that includes prevention and screening of diseases across the board. This is not just dialysis. Now you're looking at patient care as a whole, right? Respiratory care, cardiovascular care, diabetes care, behavioral health, right? So all these things, there are 36 things that are on this list. I just put a few of them here. And then you'll see that if you look at compared to, right, like what the standard is, right? So blue, meaning that dual eligible patients or low income subsidy patients, right, did worse in these things, right? Gray said that, you know what, compared to patients who are not dual eligible and low income subsidy, they did just as well. And then yellow means that they did better, right? So if you had an advantage if you were dual eligible for Medicare and Medicaid or a low income subsidy. And you'll see that across the board, right? You have, where they did better is very little, right? And the white patient population in this case, right, over 20 of the metrics, they did worse compared to other white patients who were not dual eligible. So overall, you look at the whole patient population, regardless of the disability status, they had below average scores on more than 1/3 of the measures, right? So again, this is where the socioeconomic factors take shape and kind of put in perspective our care for our patients in this great country is not so good for patients who are disadvantaged, right, from a Medicare, Medicaid perspective or low income, right? So income does play a role, right? Now, next thing, say, does geography matter, right? Now, I'm a Northeastern guy, so I thought, the Northeast is going to knock it out of the park, right? We are going to be so good, so much better than anywhere else in the country, right? So you look at the 2012 Medicare fee-for-service patients, so over 369,000 patients, and you examine trends in peritoneal dialysis and home hemodialysis initiation by race in each region, right? And you compare them to the national cohort. So I'll give you guys 5 seconds. Who do you think did the best? What part of the country would you say, like, beat everybody else in terms? Okay, so South, West, Midwest, South, Midwest, West, Midwest, East, West, South, Mid, a lot of Midwest. Okay, Northeast. Okay, Midwest, Midwest again, West. All right. So taking some of the polls, we all did terrible. We did really bad, right? Like, so like, again, if it's less than one, that means that, that it was worse, right? Than the standard that was used, right, as the measure, which was in this case the white patients, right? So, I mean, look at the Black patient population across the South, Northeast, Midwest, West, and national, right? You're in the 0.5s in all of them except for in the West there, right? The Asian patient population in comparison, again, comes very close to the white patient population, and the Hispanic patient population did better than the Black patient population, but they're still, significantly a quarter of the way worse than your average white patient here, right? So we know that overall, right, we didn't do such a good job there in crossing it, regardless of where we are. And then you look at lack of pre-dialysis education, right, which is something that we mentioned as a barrier. So there was a big study that was done across 38 European countries, and over 75% of the patients that were on dialysis said that they did not receive any form of dialysis education more than a year before they started on dialysis, right? So that's a pretty significant number. And 42% of the patients who were on dialysis said that they were not even informed of home hemodialysis as an option. So these are in-center hemodialysis patients, right? Who about half of them didn't even know that home was even an option for them, right? So in these cases, right, some of the factors that they said, aside from a lack of education, right, was lack of supervision or assistance. And we did mention that before, right? Patients think there needs to be a caregiver. How can I do this on my own? I'm going to, I prefer to do it in a center where it's clean and there's a nurse and medical team to supervise, right? Somehow we have ingrained in our psyche that the hospital and medical facilities are clean and home is dirty, right? Meanwhile, we all know in the medical field, right, that, you try to get a patient who's admitted to the hospital as quickly out of the hospital as possible because their chances of contracting a new infection are higher, right, in the hospital than it is at home, right? But somehow we've convinced ourselves that hospital equals clean, home equals dirty, right? And then the other thing is lack of availability or access to home modalities. So, and this goes back to the caregiver education, right? And we'll get to that in a second, right? But right, if your doctor doesn't know how to manage home dialysis modalities, your doctor is not going to write for you or prescribe for you a home dialysis option because they can't manage it in the first place. Or maybe you live in a part of the country where you don't even have a home dialysis providing location near you, and all you have are the local doctors in the area, and they don't even know what home dialysis is, right? So, I mean, I can't recommend to you something that I don't know. All right. Now, let's go over things for our home hemodialysis patients, right? So you say, okay, from a patient perspective, what are things that you are worried about, right, regarding being started on home dialysis? And one thing that we tend to hear a lot is that patients say, I fear of cannulation, right? I don't want to stick a needle in my arm, right? This scares me, right? I don't want to do that, right? Okay, that's what we would assume. So we said, okay, there are procedural complications, right, that patients are having, and your patients, right, are split into three in this survey. Pre-dialysis patients, so these patients did not start dialysis yet, in-center dialysis patients, and home hemodialysis patients. So you're asking their perceptions of what they're most scared about. So is it the procedure, right? Is it complications of the procedure afterwards, right? Pain, technical skills related concerns, right? Like I can't see well, my dexterity, I got fat fingers, right? Like I don't know what I'm doing. Everything? Or is it no apparent reason, right? Okay, so you'll see here, and I didn't put in everything in terms of the results for everything, because really I want you to see the top two things that won in each category. So in red is the top thing that won in each category. And you'll notice that there's no red in the pre-dialysis column, and there's no red in the HHD column. And there's only one column that I'm not showing you right now. The no apparent reason column. I don't know why. I just don't want to do it. And 71.3% of your home hemodialysis patients couldn't give you a reason for why they're scared of being on home hemodialysis, right? That is fascinating, right, to me, right? That they can't, you give them these categories, and I would be able to identify one of them for myself, right? But they say, I just, like, there's an inherent bias that you might have, even if you're on dialysis, right? Home hemodialysis, of certain things that worry you that you say, I just can't put it in words, right? I mean, a third of your pre-dialysis patients can't tell you why they just don't want to do it, right? And yes, there's a comment in the chat, right? Not knowing enough about the treatment modalities, that can be a thing, right? Overall lack of self-confidence, right? Because that doesn't fit in any of these, right? And absolutely, for the in-center patients, right, like the techs and nurses sometimes can share biases. And honestly, I've been in some practices where some physicians on the in-center side share some biases against home dialysis, right? So these are some of the things. But for me, as a clinician, I found it fascinating, right? Because we think, right, as the medical team, that we know it all, right? Yeah, it's going to be one of these. But no, sometimes it's just something that is not in these categories that you set out beforehand. Okay. There was an internet-based survey that was given to recent graduates between 2004 and 2008. So these are people who did nephrology fellowship and just graduated between 2004 and 2008, and told them, hey, on a scale of 1 to 3, rate your fellowship training in terms of 1 being little or no training, 2 being some training but not enough to feel competent, and 3 being well-trained and competent. Well-trained and competent is the goal, right? Everybody wants, right? Everybody expects, not just wants, their doctors who are now graduated nephrologists to be well-trained and competent in everything, right? 80% of them said that they felt well-trained and competent in chronic in-center hemodialysis, right? So that means 20% of them aren't. And I'm a glass half empty kind of guy sometimes. In things like this, where I expect excellence, right, I look at the 20%, right? But golly, for PD, 55.6% said that they were well-trained and competent. So about half of them aren't. And look at what it is for home hemodialysis, 15.8%. So if we look at the glass that's half empty, 44.4% of the nephrologists that graduated those years said that they're not confident in PD or competent, and 84.2% said that they're not well-trained or competent. Now, I want to reassure you all that I had a meeting with the folks at the American Board of Internal Medicine, and they asked me, what do you think we should do about this? And, you know, I gave them a whole list of things, and if something catches, then that's great. And something did catch. And actually, our current fellows are going to have more of a requirement for things to learn in terms of at least the peritoneal dialysis during their training. And there have been multiple initiatives to help combat this lack of competence, not only of the clinicians, but the confidence of the facilities that don't have home dialysis providing abilities, and therefore can't send their fellows there, right? So there's like buddy services. So when I was in New York City, for example, right, at Mount Sinai, we had some fellows from other hospitals, small community hospitals, come and round with us because their hospitals did not have a home program. Okay, I don't want to dwell on this too much because we haven't really gotten to the meat of the topic yet. Now, telehealth implementation. Telehealth, right, was fantastic. And I think that a lot of people think that this all just started during the pandemic, but that's not the case. A lot of the laws were in motion prior to the pandemic, right? So the Bipartisan Budget Act of 2018 started its services in 2019. Now, the pandemic didn't come, right, until later, right, over a year later, right? But this was all in place the year prior. And the prerequisites for using telehealth for your home patients were that for the first 3 months after they finish their training, they need to come for their monthly visit face to face. But then after that, they only need to come once every 3 months. So technically, your patient can only show up to the clinic 4 times in a year. And then the other 8 times for their monthly visits, it can be done via telehealth. Now, some restrictions, right, were changed. And before this, I had a picture, but we couldn't use it, right? But we'll go over about the changes that happened during the pandemic, right? So during the pandemic, all your monthly visits could be conducted via telehealth. You can use HIPAA and non-HIPAA compliant platforms, right? We were FaceTiming patients, WhatsApp calling patients, right? Whatever platform the patient had that you can call them with a video on, we were using it, right? Whatever you can get your hands on. No geographic restrictions. I'm in New York City, you're in California, I can be your home dialysis doctor, not a problem. Audio only visits were billable. And I can't tell you the number of patients. This is for both home hemodialysis and PD. This is what happened during the pandemic. And the rules that I said were for home hemodialysis and PD. This is for home modalities as a whole. And during the pandemic, I can't tell you the number of times I had to call a patient and be on the phone trying to explain how do you turn the video on, right? They don't know, they've never used this before, we don't know what we're doing. So audio only visits were billable. And the picture that I had was a picture of Oprah saying like, you get a car, and you get a car, and you get a car. It was you could just do whatever you want, right, during the pandemic. And then afterwards, right, once we weathered that storm, all these restrictions came back, right? So it can't be all the visits. You had to use a HIPAA compliant platform, which is good, right? There were geographic restrictions, right? So if I'm in Tennessee and my patient's in Kentucky, I can't see the patient unless I'm licensed in Kentucky. And audio only visits are no longer billable, right? You need to do at least a video visit with your patients. So the barriers to this implementation: access to stable internet, security and privacy concerns, your non-native English speakers, right? There aren't enough instructions that you have in place ahead of time to go over all this with them. Low socioeconomic status can be a boundary, and then older patients, right? Age greater than 65 are boundaries. And then, like I said, the CMS did not even extend the audio-only visits beyond December of 2023. Okay, so we'll shift gears to the myths, and I think we're doing okay on time because we're about halfway through the hour. Okay, so the first myth that I hear a lot: obese and diabetic patients cannot do peritoneal dialysis. Okay, so let's go through the concerns, right? Why can they not do it? Because insulin resistance and worsening diabetes control, right? You're giving them all this sugar with the peritoneal dialysis. They're likely to gain weight, right? There are metabolic complications, infectious complications. They're less likely to have healing around the exit site, right? So therefore their increased risk of pericatheter leaks. This patient weighs so much, the V in KT over V is so high, they're not going to be able to pass the adequacy testing. And overall, the patients have lower survival, right? So these are all the theoretical thoughts about why these patients cannot do PD. So let's go and break through them one by one. Insulin resistance and diabetes control. So yes, there is glucose content in the peritoneal dialysate that we use, with the exception of icodextrin, but we'll get to that in a second. And it's a good amount of glucose, right? So 1,360 milligrams per deciliter of glucose in your 1.5%, all the way up to 3,860 in your 4.25% bags. So pretty good amount, right? And we know that what we aim for, right, is your patient's blood glucose level of about 100, right, or less. That's your goal. So I'm putting in 30,860 in my belly, and I'm not expecting my blood glucose to shoot up. Well, on average, the glucose absorption from the peritoneal fluid is anywhere from 80 to 220 grams, right, per day, right, in the treatment. So thankfully, they're not absorbing 3,000 of the 3,860, but 80 to 220 can be enough to tip the scales, right, for these patients. And there's a comment about connecting with the endocrinologist. Absolutely, right? That is one thing to consider. When your patient starts on peritoneal dialysis and they're on insulin, and you identify their endocrinologist and you let them know, hey, things are about to change right now. Your patient's glucose levels are going to go high, and don't be surprised if that's the case, and they can increase the dose of the insulin that they're using. And during the treatments, if you're going to change the prescription to increase the percentage, right, of the dextrose and the bags, let them know, because then they're going to need to subsequently increase the insulin dose that they use. So there's something called the transfer status, right? So you have patients that are high. It used to be called transporters, but now we're moving to transfer as the term to use. So high transporters, high average transporters, low average transporters, and low transporters. And the higher your transport status, the greater the amount of glucose that you're going to be absorbing, right? And you'll see here for each transfer status, right, there are 3 bars, one for each concentration of dextrose solution that we use. Yeah, so just real quick, a comment on the point. So 80 to 220 grams for CAPD or APD. So this is on average for CAPD. A lot of the studies that were done on CAPD patients. There is a poor amount of studies that were done on APD patients, and that's something that I'm trying to change in terms of the clinical studies that I'm doing, because I'm doing them on APD patients and APD focused patients, because as a recent publication showed, over 80% of patients in the United States are on APD, right? I believe the number is actually over 90, but at least, I know for sure at least 80% are on APD. And then telling patients PD doesn't last forever, that is true. And the higher the transfer status in these patients, right, the lower the time that membrane is going to last, because over time, your patient's transfer status gets faster, right? So if your patient's already starting at high, right, it's not going to be around for long. We can't tell you exactly how long. It can be like, if it's high, it's going to last for 2 years. If it's high, it depends on the prescription. It depends on the peritonitis rates for your patient, right? There are a number of things that factor into it. But I digress. Let me go back to the absorption, right? So this kind of puts in perspective for you, right, as patients, as providers, right? If your patient's the high average transporter, their glucose absorption is going to be higher. So you're going to be closer to that 220 that we talked about. Okay, glucose intolerance, right? So my patient now, right, they're going to develop diabetes, or their diabetes control is going to get worse, right, because they're on PD. So if you look at the rates of new onset diabetes, this is in dialysis patients on both hemodialysis and in-center, both on peritoneal dialysis and in-center hemodialysis. So anywhere from 3.8 to 13.8%. New onset impaired glucose tolerance, 15% of your patients. New onset impaired fasting glucose, about 1/3 of your patients, right, can get that, right? So this is both in PD and in-center dialysis. And you can turn around, and rightfully so, and tell me, hey, like the glucose concentration in in-center hemodialysis that's running is 100, right? Like, why would these patients get this? And I'll turn around and tell you, but that's going directly into your patient's blood, right? So if that's going directly into your patient's blood, it's very different than when you're putting it into the peritoneal membrane and then you're relying on whatever gets absorbed, right? That's where the difference lies. Okay, but what if we compare new onset diabetes in patients then that were started on PD compared to patients that were started on HD? Okay, any guesses as to which one would be more? And by the way, I see the question about icodextrin, and we'll get to icodextrin, Linda, so don't worry about that. We'll get to that. Any guesses as to which one caused more new onset diabetes? Would you think it was PD or HD? Okay, so mixed bag, we're getting PD, HD, PD, HD, PD. So I think it's about 50-50 right now. Okay, good. That's good. All right, so they were even. There was no significant difference between them, right? So yes, there is a large amount of glucose that's going into the peritoneal membrane, but overall, compared to your HD patients, new onset diabetes is going to be equal across both PD and HD. Remember, there's a big asterisk, right? With the big asterisk is, if I'm starting all my patients on 4.25% dextrose, then yeah, I'm going to tilt those scales eventually, right? So this is kind of doing what's clinically, but overall, right, assuming you're clinically sound with your reasoning, you'll find that your patients on average, the new onset diabetes is going to be about the same. So the conclusion is about half of the PD patients may develop a glucose disorder, right? So these percentages that we're looking at, right, I'm saying the chances that your patient will get one of these three things: new onset diabetes, new onset impaired glucose tolerance, new onset impaired fasting glucose, it's about 50%. But the incidence of new onset diabetes between PD and HD is the same, as far as we know. Now, weight gain, right? You're giving these patients all this sugar. There are calories in these bags, right? So you're giving it to them, the 1.5% bag, right? Even if you're doing 2 liters, that's 111 kilocalories. The 4.25 is 315 kilocalories. And on average, your patients absorb 400 to 800 kilocalories per day, right? While they're on peritoneal dialysis, right? So, I mean, that's almost a meal, right, that they're taking in. So if I told you, if you ate an extra meal every single day on top of your meals that you normally eat, I would expect you to gain weight, right? But again, remember, some of our patients that are on PD, the PD does affect their appetite, right? They don't eat as much. And in general, end-stage renal disease patients, on average, don't tend to have the same appetite as non-end-stage renal disease patients. If you look at weight gain in PD versus HD, you'll notice that after 2 years of starting dialysis, right, the body fat in those patients is about the same, right? So these lines, right, they're super close. I mean, this is within 0.5, less than 0.5 of each other, right? Because each gap between these two lines is 0.5. So this is what, like 0.2, right, difference in terms of the body fat in percentages. The weight gain during PD, this was studied looking at 114 patients that started PD and were treated for at least 2 years. And they looked at 8, and they found that 8 patients out of the 114, which is about 7%, gained more than or equal to 10 kilograms of their initial weight. And there's not something there that stands out specifically. I mean, they're more likely to be males, they're more likely to be 51 years old, they're more likely to be well-nourished, normotensive, so these aren't hypertensive patients. They were non-diabetics. Their dialysis adequacy was great. They had some residual kidney function, but it was little, but they were high average transporters. Now, the high average transporters is not much of a surprise, right? Because we said there are 4 different transfer rates, right? So high average is really the second to the highest, right? So those patients are more likely to absorb these calories and the glucose from their fluid. So the solution, and this is where we're going to touch on icodextrin. First of all, try to minimize the dextrose concentration of the solutions that you use as much as possible. You need to be able to remove fluid, right? But if that was the case, right, then like you can, right, you can burn out the patient's PD membrane by putting everybody on 4.25%, right? But there are patients where 1.5% does the job very well, right? And then the other thing is, if you're going to do an extended well, you can use icodextrin. Icodextrin, also known as extraneal, it's a high molecular weight glucose polymer that is not absorbed in the same way that glucose is absorbed. Icodextrin is absorbed through the lymphatic system, right? And when they did the studies, and I couldn't share the graphs here, but there's no effect of icodextrin on glucose levels in patients and insulin levels in patients during a long dwell, which tells you that you're not absorbing it into your system to the same effect that if you did it for dextrose, right? So if there's no effect on glucose or insulin, right? Because if they just did the test on glucose, you can turn around and say, well, you just made more insulin and that made up for it, right? But if there's a more insulin either, then you know that overall there's no shift in terms of your body's equilibrium while you're on icodextrin. Now, we normally say, right, like don't recommend it to be used, and it's not FDA approved to be used for your regular exchanges, right? So to go back to the question about just, do you just use icodextrin then for those patients, the standard of care for everything? I would say no, I would use the icodextrin as my extended dwell solution. I would try to minimize the dextrose concentration as much as I can for the regular overnight treatments, right? So you can get sustained ultrafiltration over a 12-hour period along with clearance that reduces the caloric load, right, for your patients, and we normally use it as a last fill or a longer dwell time. So if you have CAPD and you want to have like an overnight dwell, we recommend using icodextrin. Now, infectious complications. So Because of the thought process that patients who are obese are less likely to have healing, right, around the exit site, and they're less likely to be able to kind of see and take care of the area around their panis compared to slimmer patients. There was a study that was done over the course of 10 years looking at 938 PD patients and over 1,000 episodes of peritonitis. And they divided the patients into quartiles based on their BMI. So they were different teams 1 through 4. 1 had the lowest BMI range, 4 had the highest BMI range, right? So the 4 goes all the way from 30.5 to 59.2. And then they looked at the most common things, right? I mean, they had the whole list of things, but I couldn't just include them all here because I think it would be too much. But normally we tend to think of Staph aureus, fungal infections, any strep species, right, for the peritonitis. And you'll see overall there was no association between the BMI level and the rate of exit site infection, right? These numbers are similar across each row. So it's not statistically significant. It's important things to consider, right? When you have your patient who's obese and has a big panis, do you want to put the PD catheter under the panis where they can't see it? If your patient can't see it, don't put the PD catheter exit site there. The PD catheter exit site needs to be in the upper abdomen, or if you have an expert surgeon who really knows how to do this and is well versed at it, right? You can place a pre-sternal PD catheter. I don't know anybody in my area who's not. I know a couple of surgeons in the country who do it, but you won't see pre-sternal very often. But that is a place where you can place the catheter. Let me see. There's a quick question here. Would you use a back-to-back ICO over 4.25% in diabetic patients? I have, but that was in a case where a patient was failing adequacy and really did not want to go on any other dialysis modality and said, please, 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 is there anything we can do? And that patient did have some residual kidney function to support it. Okay. Now, lower dialysis adequacy, right? So we talk about the adequacy because we said that the V in your obese patients is very high, right? So you look at the KT over V. V is calculated using the Watson equation. Now, one thing to know is that the Watson equation was derived on healthy controls. These are patients that are without edema, and they definitely were not on dialysis. And I tell this to my nurses, right? And, you know, I know a couple of them said that they would tune in, right? But fat cells cannot be dialyzed, right? So you have your patient showing up, right, with a BMI of 45, right? And then you put in your V, right, this patient's weight, right, as their actual body weight, right? What are you cleaning? What are you expecting the dialysis to do, right? 10 kilograms of muscle has much more water in it which is what you're taking and cleaning, than 10 kilograms of fat. 10 kilograms of fat has 10% of the water content in muscle and skin cells. So therefore, at higher BMIs, especially greater than 30, your total body weight will be falsely high since the body fat contains very little water. And in these cases, we recommend using the ideal or the adjusted body weight. And I'm going to show you real quick here in a clinical case. Let's say you have a 65-year-old woman, comes to your clinic, she's on dialysis, she's 200 pounds, 5'1". That BMI is 37.8. She's been on PD for 6 years. You look at her labs, and her labs overall look fantastic, right? I'm okay with these numbers, right? PTH is fine, calcium's fine, albumin's fine, electrolytes are all fine. This is the current PD prescription. APD, 5 cycles, the fill volume is 2.5 liters, treatment time is 10 hours, you're using the 2.5%, sometimes you use the 4.25, but for the most part, you're using the greenbacks, 2.5, and you're using a last fill of 2 liters of icodextrin. But your patient's KT over V is 1.4, so you're not reaching your target of 1.7 for this patient. So remember, 5 cycles over 10 hours with a last fill of 2 liters, and you're using icodextrin as your last fill, and you're using 2.5% for the most part as your solution of choice for their treatments. So my question to you is this: what would you do in this case for this patient? Would you increase their number of cycles or increase their number of hours on the cycler? would you add an additional midday exchange for this patient, or would you do something else? So A, B, or C. So we're getting B, 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 A, B, 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 a couple of C's. A PET was suggested in there. Depends on their membrane type, sure. Okay, B, B, B. Okay, a lot of B's, some C's. The membrane type, I think the membrane type comment is a good comment because, right, increasing the number of cycles versus the hours depends on if your patient's a fast transporter and you think that their dwell time in this case is too short and you need to extend it if they're a slow transporter, or if the dwell time is too long because they're a faster transporter and then you want to shorten it. So I think that's a warranted thing. So I would tell you, I would do C. I would do something else, right? This patient's doing fantastic. I'm cleaning the blood very well in terms of managing the electrolytes. And the patient's BUN in this case, right? So if we go back, the BUN was 45. That's a dream BUN for your dialysis patient. I'll be happy with that, right? So the solution is I would use the ideal body weight or the adjusted body weight. I tend to use the adjusted body weight in this case, okay, for my KTOV calculation. And for those who are curious, there are different equations, but we tend to use the ideal body weight plus 0.4 times the difference between the actual body weight and the ideal body weight, okay? And so if we go back, you're right, and don't do that in your malnourished patients, okay? So again, this is for your obese patients. Okay, for your malnourished patients, use their actual body weight. But if we go back to this clinical case, right? This was a 200-pound patient, which means it's equivalent of 91 kilograms. If you use the adjusted body weight, right, that V goes down to 65 kilos. If you use the ideal body weight, that V goes down to 48. And look at how that compares. Your V, if you use the ideal, almost halved. And if you use the adjusted, it's down by about a third, right? And your patient will pass the KT over V. And somebody can turn around and say, this is gaming the system. And I'll tell you, no, this is physiologically sound because you can't dialyze fat. And you're not harming your patient because all your patient's labs are fantastic, right? If the patient's B1 was 120, right? You know you're not doing good clearance, right? Therefore, you can increase the prescription. It's a clinical decision, right? But if you're setting V at an unrealistic target, you're not doing your patient any favors in this case. Okay. Now, obesity and survival. So I like to say this, just like everything in life, most things are U-shaped in terms of too little of something is bad, too much of something is bad, somewhere in between is the best. So if you look at 14,000 incident peritoneal dialysis and 28,000 incident hemodialysis patients, and you look at their BMI, age, sex, race, ethnicity, and then look at the BMI ranges. So each dot on this curve is the BMI. So less than 20, 20 to less than 25, all the way up to 40 or more. If the red line crosses under 1, right, that dark line of 1, that means that the patients are more likely to survive. So anywhere from 20 to just under 40, there's actually a survival benefit for those patients. So does that mean that I'm telling you that, hey, you know, tell your patients to go and eat, right? Go to your nearest buffet and go wild, right? Because who cares about your BMI? You can go up to like just on 39 and you're going to live longer than if you were like, you know, 18, 19. No, BMI on its own, right, is not enough. But I'm just saying that your patients who are on the heavier side, they're not more likely to die because of that. They have a survival benefit. And the main reasoning here is nutrition, right? Those patients are more likely to be better nourished compared to your malnourished patients with BMIs less than 20 and your patients who are morbidly obese with BMIs over 40, right? So the nutritional status in your patients, right? Like it's music to my ears when I have a very thin patient starting dialysis who then tells me in the following months after they started, you know, my appetite's better, I'm eating more, I'm gaining weight, right? Like that is, for me, that's a good thing, right? That means that I'm doing my job, their appetite's getting better, the uremia is going away. Now, patients with liver cirrhosis can't do PD. So if you look at dialysis patients, right? So you want to do dialysis in cirrhotic patients. How do you think hemodialysis does compared to peritoneal dialysis? Which one do you think is better? Hemodialysis or peritoneal dialysis in your cirrhotic patients? PD, 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 1HD, PD, 1HD, PD. Okay, yep. So PD patients, right? If you look at your patients, the all-cause mortality for your PD patients compared to your hemodialysis patients is 0.48, which meaning they have 52% higher chance of living. And if you look at your cirrhotic patients compared to your non-cirrhotic patients that are on peritoneal dialysis, there's no difference in mortality. There's no difference in hernia formation. There's no difference in their transition from peritoneal dialysis to hemodialysis. But there is a higher incidence of hypotension in those patients. So in cirrhotic patients on PD compared to non-cirrhotic patients on PD, right? I mean, the disease is worse in cirrhotic patients, so there's more likely to be hypotension, and there's a higher incidence of peritonitis in those patients, slightly higher. So the odds ratio is 1.1, but it is slightly higher in those patients, right? And I'll tell you, one of my mentors, she's in Canada. Whenever I call her about a cirrhotic patient, she just tells me, Osama, don't do it. It's bad news. This patient's not going to do well. You should probably be talking about quality of life and medical management with this patient, but just something to consider. Next thing, patients with heart failure cannot do PD. Now, I know we're getting close to the top of the hour, but this was a statement from the American Heart Association in conjunction with some colleagues of mine from nephrology. And this is what they said in their statement. Home dialysis, including home hemo and PD, provides a more physiological approach to dialysis and under many circumstances can lead to improved cardiovascular outcomes compared to with traditional thrice weekly in-center hemodialysis, right? These are the cardiologists telling the world home hemo and PD are more physiologic. And that's why I tell patients, your kidney works 24/7, 7 days a week, 365 days in a year. It doesn't work 3 times a week, right, for 3.5 to 4 hours, right? So we try to mimic that as much as we can, and we try to be as gentle as we can with our patients. Now, peritoneal dialysis in heart failure patients, there's no difference in mortality in heart failure patients, whether they did peritoneal dialysis or they did ultrafiltration or hemodialysis. There was also found a general improvement in your patient's left ventricular ejection fraction. So 7 studies saw that there was an increase in your patients with heart failure's ejection fraction by 10% from baseline, with up to a 31.1% increase. Right? So, and I see this a lot in patients that are admitted to the hospital. A lot of the cardiologists like to veer away from PD and do HD because they say, well, we can remove more fluid this way. And I think, honestly, for me, I think that it's because when you put your patient on HD, you can set to whatever number you want and walk away, right? Knowing that you're going to get that number. But with PD, right, you're adjusting the prescription, you're trying to get to the goal ultrafiltration that you want. So it's more of a dance, right? And people who are not nephrologists or people who are not well versed in this, right, they don't want it. I'm not a good dancer, but I'll dance in dialysis all day, okay? But that's me, right? Not everybody wants to do that. You want to set a machine, get the machine to do the work, and then leave knowing that you're going to have that removed. But why introduce a tunneled or like a central venous catheter to my patient who's on PD while they're in the hospital, right? And like somebody wrote in the comments, increase the risk of central venous catheter infections, and now you just have an extra access in your neck for no reason, when I can just do the same thing with peritoneal dialysis, remove the fluid, and potentially help improve your patient's ejection fraction. Now, patients with prior abdominal surgeries cannot do PD. Okay, so in those cases, we normally have patients be evaluated by a surgeon rather than an interventional nephrologist or like percutaneous placement, because we want them to take a look inside the abdomen and see how many adhesions are there, right? In this case for your patients. And adhesions are these connections that form kind of like almost like scar tissue webs that form between your organs and the wall of the abdomen after a surgery. So how many adhesions are there? And then we tell patients, listen, there's a chance that your peritoneal dialysis may not work well, right? But we honor your decision to try PD. Let's do it, right? Let's give it a shot, right? So we do our best. Now, of course, if your patient has like, 7 abdominal scars, the chances of it working are much lower than a patient who, like, let's say, just had a C-section, right? And there's a small scar at the bottom, right? And you're like, okay, you know, we can probably work, or like I had an appendectomy in the past, right? So there was a study that was fresh, you know, hot off the press, published in CJASN, that was looking at 785 PD patients across the US and Canada. And then if you look at the flow restrictions in your patients, the patients who had prior surgeries had 17% number of, so the patients prior surgeries and had adhesions, 17% of them had flow restrictions compared to 13% of the patients without adhesions, and 10% had abdominal pain compared to 8% of those without adhesions. And the hazard ratios are statistically significant, but you see it goes down to as low as 1.05 and 1.04. And honestly, if I was a patient starting dialysis and you told me, you know what, there is a 10% chance that because you had the surgery and you have an adhesion, that you're going to have some abdominal pain when you're doing PD, compared to 8%, right? If you hadn't had a surgery. For me personally, big picture, clinically looking at my patients, what is 2%, right? Like as a patient, right? If it's 80 and 10, sure, right? But it's just something to tell your patients, right? But it's a 2% difference. And flow restrictions, it's a 4% difference, right, in these patients. So again, not such a huge difference, right, in terms of the conversation. Okay, now finally, pets and dialysis, right? So previously, right, the bacteria that you're worried about is Pasteurella. And I say previously because Pasteurella still exists, but the thought process was it's cats. Cats are the culprits, and the slide that I used to have was a collection of case reports. It was 44 cases, right? And all of them had cats, and then 1 had a dog, and 2 had a cat and a dog, right? So the cats got a bad rap, and everyone said, well, you know, you need to isolate your cats during the treatments. But then the most recent study that was published as part of the PDOPS group, right, which is the Peritoneal Dialysis Outcomes and Practice Pattern Study, published in 2023, showed actually they all crossed the hazard ratio of 1, except for patients that have both cats and dogs. So what does that mean? If somebody has cats and dogs, then they'll have to give it up. I'll use a line one of my mentors says. He tells me, if you tell a patient to give up their cat or dog for you because they're doing dialysis, they're going to give you up. They'd rather give you up and go find somebody else who's going to tell them, you know what, you can do this with a cat and dog, right? And I don't blame them. So in this case, right, patients that have both cats and dogs are the most likely to have it. So what do? You tell the patients, these are, you know, the steps that you follow. Keep your pets in another room during your treatments, right? Especially when you're connecting and disconnecting, right? Curious paws and puppy sharp teeth can find their way to your dialysis machine tubing. And some patients will tell you, you know, my cat sleeps with me on the bed. Okay, well, like you need to find a way to kind of separate the cat at least during the connection and disconnection, and then potentially cover the tubing, because especially if you're doing peritoneal dialysis, cats love following these bubbles that they see sometimes, right? And that's what they chase. So it's something to consider there. If possible, store your supplies in a different room and keep that room door closed. Wash your hands frequently, especially after you feed, right, your pet, or cleaning them. And most importantly, again, before you connect and disconnect to the dialysis machine, that's where things are kind of exposed to the environment the most. Pet nails, make sure you trim them, right? Clip the nails, right, of your pets. I'm not saying remove the nails, I'm saying clip the nails, right? So the scratch, because the scratches can spread disease, and cats and dogs, right, they lick their paws, and that's where the Pasteurella then can be transmitted. And if you have a cat or a bird, and there's a litter box or a bird cage, have somebody else clean it, right? Or if you clean it, make sure you really clean your hands very, very well afterwards. And then frequently clean your furniture and your floors to reduce fur and dander and keep your pet healthy, right? A healthy pet is less likely to transfer any diseases to you. Okay, and I think with that, I'd like to conclude, and I'm happy to take any questions.
Thank you, Dr. Shamy. What a great presentation, and the chat's been very busy over here.
Yeah.
And you answered quite a few. I just want to, oh gosh, it went by me already. Somebody has put in there, I always had my cat on me and dogs while I did my HHD treatments, never got an infection. And she was also solo. So that was a nice compliment to you talking about pets and everything. So
thank you. I just want to say one thing real quick. Actually, somebody asked about the equation for the ideal body weight. So that you can plug it in to like the MD Calc online calculation, right? You could just put your patient's gender, their height, and their weight, and it will give you their ideal body weight. Or there are tables, right, where you have your patient's height and the gender, and it will give you what the patient's ideal body weight is.
Great. Okay, well, great. Thank you so much. And just in time, we're just going to wrap up then. Thank you again, everybody, for being here, taking time out of your day. I think it was a great presentation. We had a great audience, a lot of, I think, participation and collaboration going on in the chat. So just a little bit of a few things before we go, just moving from learning to action. So there was a lot of best practices here that you heard today. So we ask that you go take this back to your facility, hopefully implement one within the next day or couple of months, weeks, and share this best practice with your teammates. I know somebody asked me where these slides will be. Again, about 5 to 7 days, these are going to get posted on the ESRD NCC website. You'll also be receiving an email within the next couple days with, again, where that's going to be, where they're posted at, how you access it, and we'll put the links into our website in there also. So you'll get a couple emails from us. And also, if you go to the next slide, I think at the conclusion, there's been a couple people ask me again about CEUs. When this call concludes, you'll be getting an email. It will have a quick, short survey. We really ask for your feedback. We always like to improve and what we could do better on these calls. So please take a few minutes to fill that out. And then also there'll be links to the CEUs. So I think this concludes our call. Thank you very much.
Sorry.
Once again, thank you to our speaker, Dr. Shamy. Appreciate your time and you taking, being here with us, taking time out of your busy schedule. And thank you for everybody else being here also. We really appreciate it. Take care, everybody. This concludes our call and take care.
Thank you all so much. Take care.